CDE series of webinar. This is the subject-specific webinar of biochemistry, and I welcome all of you along with Dr. Vidya and Dr. Seema and my dear friend Dr. Surpam. So the topic is intracellular homocysteine, a better indicator for B12 deficiency. The more we read, it is like opening a Pandora's box, as Dr. Seema said. And I cannot I cannot not believe her. It's really very, very important. So it's in spite of being a Saturday, and I think most of us are finishing our work, but it's nice to see numbers, and that just speaks very highly about the topic. I have my dear friend, Dr. Vidya, who is the moderator, who is going to be talking about, our speaker. Before that, I want to tell you that in CAHO, we believe in training and we are committed to patient safety and safer healthcare. I thank my committee as a chairman and also Dr. Vijay Agarwal and Dr. Lallu Joseph, who are from the CAHO Central. Please do visit our website www.caho.in for further details. Our next webinar is on 11th of May. That's next Saturday between 5 to 7. And the topic is amazing, good special hematology by Dr. Sumit Bhatia, who is from US, and Kunal Sehgal, who is a renowned hematopathologist. That is a bone marrow evaluation. Please register on these links. It's free, but good education. Now over to Dr. Vidya, who is my dear, dear friend, comes from Mangalgiri. She's a professor and head of Department of Biochemistry, AIMS Mangalgiri. Over to you, Vidya. She'll be there throughout the webinar for you all to assist your question answers. Please visit our website. Do give your feedback about any more topics you want to hear from us. And over to you, Dr. Vidya.
Yes. Good evening, one and all. At the outset, I express my heartfelt thanks to Dr. Rapana ma'am for giving us the platform, and at the same breath to Dr. Vijay Agarwal sir and Lalu Joseph madam. I believe this continuous diagnostic events is definitely a platform where we are going to integrate. And as all of us know, lab professionals have a major role in diagnosis, monitoring, and prognosis. So we brought up this topic because vitamin B12 deficiency is considered as an endemic nutritional disorder. And there are so many studies, according to the NHEAS data, it is saying that the epidemiology says that in children above 19 years and old, the B12 deficiency is 3.6%, and above 60 years, it is 3.7%. Similarly, vitamin B12 insufficiency, which we hardly try to come to know by the routine diagnostic test, it's around 12.5 to 12.7%. And also, we are telling that 21% of them have abnormal levels of B12 deficiency, which is gone unnoticed. So early diagnosis is very important. So we took up this topic of how we can really identify B12 deficiency, and hence we can treat them earlier. There's a study by Department of Endocrinology, Kalpavriksha Healthcare, New Delhi, India, which they have done in urban population. This is really alarming, which says 37.76% of pre-diabetes all have B12 deficiency. 31.23% endocrine disorders have B12 deficiency, and 18.25% of diabetic people have B12 deficiency. So we really understand how B12 deficiency, coming to a diagnosis of B12 deficiency and hence treating, major role depends on the laboratories. We have to give accurate results so that the treating physician can treat them properly and we can have a quality health outcome. We all know B12 is involved in cancer, cardiovascular disease, stroke and dementia, and cognitive function. So with this brief introduction, today's speaker, I take the privilege of introducing Dr. Seema Shah. She is a young, dynamic, additional professor of biochemistry. She is from AIMS Raipur. I'll read out a few achievements. The list is big. I've briefed it up. She's a fellow IMSA 2023, She has been introduced 4E module for MBBS students for Kindle edition with audio video by Elsevier India. She is a recipient of gold medal in medicine and surgery, Divya Singh Chawla gold medal. She is also a recipient of Rajnikant Memorial Gold Medal in pathology and microbiology 2001. She has more than 35 papers published in high index journals. Her ongoing research is in sickle cell disease, which is a ICMR multicentric, and her main area of interest is diabetes and metabolic syndrome and lung cancer. As Aparna ma'am said, this evening, let us have this intellectual platform, and over to Dr. Seema.
A very good afternoon to one and all present here, particularly thank you so much, Dr. Aparna Jairam, chairperson of the event, and Dr. Vijay Agarwal sir, who is organizer of KAHO. I'm extremely thankful to Dr. Vidya Desai, who invited me for this topic, though initially I was a bit reluctant saying that vacation is going on, but it is really an interesting topic, and while researching on it, it was for me like opening a Pandora's box. So again, I would thank everyone from the KAHO, chairperson Dr. Aparna Jairam, Dr. Vidya madam, and of course all the audiences who is because of them this continuing diagnostic education is actually getting continued. So I would start my topic of intracellular homocysteine, a biomarker of vitamin B12 deficiency with a case. Cellular homocysteine, a better indicator for B12 deficiency. I would like to start the topic with a discussion of a case. A 57-year-old male reports increasing symptoms of painful paresthesia and numbness in both the legs for the past 18 months. So we know that any neurological manifestations like paresthesia, painful sensation, should definitely raise a concern of vitamin B12 deficiency. So physical examination of this person revealed impaired sense of position and vibration. So the clinician ordered measurement of B12 level, but surprisingly, vitamin B12 level in serum was found to be 365 picogram per milliliter. And the cutoff for diagnosing lower B12 level is the 250 picogram per ml. So clearly, the patient has documented level of vitamin B12 was way above the cutoff for diagnosis. So how should this patient be further evaluated and treated? So just before the introduction of the talk, as Vidya madam told, vitamin B12 deficiency is endemic. A very good number of persons are having vitamin B12 deficiency, but it is mainly underreported. If we look at the reported papers, published paper, one of the paper published in 2009 says that in US and UK, around 6% of people above the age of 60 years are deficient in vitamin B12. Similarly, one paper was published in 2004 by Andres et al., which says that prevalence of cobalamin deficiency can be as high as 60% depending on what definition of diagnosis is being used. So we can see that prevalence can be 5 to 60%. If we talk about the clinical presentation of vitamin B12, we all know that classically we talk about anemia, that is particularly megaloblastic anemia. And second is neuropsychiatric manifestations in the form of paresthesia or more dreaded complication like subacute combined regeneration of the spinal cord, which can lead to lifelong paralysis. But vitamin B12 is more of a metabolic defect, more of a metabolic disease, which has a very heterogeneous presentation. The presentation can be simply in the form of cutaneous manifestations like hyperpigmentation or vitiligo. It can be in the form of anemia and thrombocytopenia. It can be neurological manifestation, as we just discussed, like paresthesia, feeling of pain and numbness in the limb, hyperreflexia, even gait abnormality, and in a more complicated case, it can be subacute combined degeneration of cord, brain atrophy. And nowadays, lot of psychiatric manifestations are also being seen in vitamin B12 deficiencies, which are called as megaloblastic madness, ranging from simple depression, manic features, irritability, and even suicidal tendency. So, because of these heterogeneous presentations, heterogeneous clinical presentation, a high degree of suspicion by the clinician is a must. And clinical feature alone cannot diagnose the vitamin B12 deficiency, and we need laboratory parameter to actually diagnose the case. However, most of the B12 deficient patients do not have hematologic manifestations. And again, neurological manifestations are also not mandatorily present. If we look at the published literature, when vitamin B12 was measured, then 3.2% of US adults showed a level less than 200 picogram per ml in age group over 50 years. This is about the documented vitamin B12 level. However, there is poor correlation between B12 level and the symptoms the patient may present with. Further, even people who are having low amount of B12, even lower than 140 picomole per liter, may have absolutely no symptoms. Further, those persons who are supplemented with oral vitamin B12, their serum level of vitamin B12 increases without any benefit in the symptoms, because it hardly raises the tissue level of vitamin B12. So we can say that B12 alone for diagnosis of vitamin B12 deficiency or for monitoring of the treatment is not enough. That's why the need of a better biomarker becomes more important. So before talking about what biomarkers we can use for diagnosing vitamin B12 deficiency, we must understand how vitamin B12 is assimilated in the body. So if we look at the dietary cobalamin, this dietary cobalamin remains present bound to the animal protein, P protein. Once inside the stomach, this gastric pepsin and the hydrochloric acid, it cleaves the animal protein from the cobalamin, and cobalamin gets bound to the R protein released from the parietal cell or those from the salivary R protein. So cobalamin R protein complex now travels to the duodenum. Simultaneously, the gallbladder from the bile also cobalamin R protein complex is also released into the duodenum. Inside the duodenum, the pancreatic tryptase digestion, because of this pancreatic protease digestion, this R protein is cleaved from the cobalamin and a free cobalamin is released. Now, simultaneously, the parietal cells of the stomach produces intrinsic factor. This intrinsic factor now gets bind to the cobalamin in the duodenum. And now this cobalamin intrinsic factor complex travels to the distal part of ileum. In the distal part of the ileum, this cobalamin intrinsic factor complex is taken up inside the enterocyte through a receptor called tubulin. And inside this enterocyte, then it fuses with the lysosome and cobalamin is set free. But cobalamin, to go to its target cell, it needs to enter into the systemic circulation. So cobalamin gets bound to few proteins called transcobalamin. We have transcobalamin 1, 2, and 3. So cobalamin binds to all the three, and this cobalamin transcobalamin complex gets transported into the blood. However, out of this TC1 2, and 3, only the cobalamin bound to TC2 is taken up by the target cells. So, though the circulating cobalamin, the total B12 level represents all the three, actually the functional B12 is only that fraction which is bound to the transcobalamin 2. So once it is taken up by the target cell, then it gets cleaved inside the cell and then gets converted to its active form, that is adenosyl cobalamin and methyl cobalamin, and exerts its effect. So during the assimilation, be it any defect like a defect in the synthesis of intrinsic factor or some antibody to intrinsic factor, then we have transcobalamin synthesis defect, or we have defect into the TC2. All these can lead to deficiency of vitamin B12. Apart from these, any resection of the distal part of the ileum or intake of drugs like proton pump inhibitor, which will decrease the acid in the stomach, can also lead to B12 deficiency because it will interfere with the absorption of B12. So from the assimilation of B12, now we have come up with three markers. One is antibody to intrinsic factor. Another is cobalamin TC2 complex, that is holotranscobalamin. And the third one, which we are already using, that is the circulating or the serum B12 level. So these three are the biomarkers which we can use to know further, like there are more number of biomarker, as our topic itself is on homocysteine. So we need to see the biochemical pathway to know what are those biomarkers and what are their strength and limitations. The key to strength and limitations actually lie in the elucidation of the biochemical pathway. So we'll quickly see the biochemical pathway in which B12 is playing a role. So B12 is one of the vitamin which is very important for the functioning of the folic acid, which is vitamin B9. As we all know, vitamin B9 is dietary vitamin B9 or folic acid is first converted to dihydrofolate and then is activated to tetrahydrofolate, which is the active form of folic acid. The folic acid during 1-carbon metabolism is converted to 5,10-methylene tetrahydrofolate, which is further reduced to methyl tetrahydrofolate by an enzyme called MTHFR or methylene tetrahydrofolate reductase. Now, the interesting point to note here is that the only way methyl tetrahydrofolate can be converted back to tetrahydrofolate is by using cobalamin as an acceptor of the methyl group. So unless and until we have cobalamin, this folate would get trapped in the form of methyl tetrahydrofolate, which is popularly known as the folate trap. So once the cobalamin reacts with methyl tetrahydrofolate, we get what we call it as a methyl B12 or methyl cobalamin, which is the first biological active form of B12. So B12 deficiency or any defect in the any deficiency in the tetrahydrofolate, any defect in this gene coding for MTHFR can also lead to B12 deficiency. Now, after generation of methyl B12, what is the key pathway which will give us the another biomolecule? Now, the key pathway is in the metabolism of sulfur-containing amino acid, that is methionine. It's an essential amino acid, and during its metabolism, it gets converted to acetinosyl methionine, which is the active form of methionine, and then further downstream in its metabolic pathway, it produces a biomolecule called homocysteine. Now, homocysteine is talked about not just with relation to B12 deficiency, rather homocysteine has got more familiarity as a risk factor for cardiovascular disease. Now, high homocysteine is considered a risk factor for so many diseases, and particularly more so for cardiovascular disease. So the only way homocysteine can be reduced from the body is either by its conversion into cystathionine and cysteine, which then further can be utilized for formation of glutathione, or by remethylation of homocysteine to regenerate the methionine. So if you look at the first pathway, that is homocysteine, in presence of another vitamin, that is pyridoxine, condenses with a amino acid serine to form cystathionine, which is catalyzed by cystathionine beta synthase, and then further by cystathionine E lyase, it can form cysteine. So any defect in this two enzyme, that is cystathionine beta synthase or cystathionine E lyase, or deficiency in B6 will also cause rise in homocysteine level. Another pathway by which homocysteine can be reduced is by regeneration of methionine, but for that we need a methyl donor. And here the methyl donor is of course the methyl cobalamin. So homocysteine will take up the methyl group from methyl cobalamin and will regenerate the methionine. So now here is our molecule, that is your total homocysteine, which can be affected by B12 level because of affection of this pathway. But again, this can rise because of anything like simple deficiency of B6, because of some enzymatic defect in the CBS or CAC, or because of folate deficiency, or because of some mutation in the MTHFR gene. So now we have the second biomarker, that is homocysteine. Coming to another metabolic role of vitamin B12, we know that metabolism of odd chain fatty acid and branch chain amino acid like valine, isoleucine, methionine, they all produce 3-carbon moiety, that is propionyl CoA. The propionyl CoA enters the TCA cycle in the form of succinyl CoA, but during this process, it produces initially methyl malonyl CoA and then L-methyl malonyl CoA. The L-methyl malonyl CoA is converted to succinyl CoA by an enzyme called methyl malonyl CoA mutase, which requires adenosine cobalamin, that is another active form of cobalamin or B12, to form succinyl CoA. So any deficiency of adenosine cobalamin is going to affect this pathway, leading to accumulation of methyl malonyl CoA, which is then converted to methyl malonic acid. That is the another biomarker of the B12 deficiency. So now our list is for expanded biomarker list for B12 deficiency is serum B12, total homocysteine, methyl malonic acid, and holotranscobalamin, that is the transcobalamin TC2 bound vitamin B12. And to know about the malabsorption, we can also go for measuring the antibody to intrinsic factor and to parietal cells. If we talk about the stages of B12 insufficiency, it develops through changes in the blood, like raising of plasma, MMA and urine MMA excretion, decrease in the serum holo-TC, holotranscobalamin, increased plasma to homocysteine concentration, reduction of the RBC B12 level, hypersegmented nucleus of neutrophil, megaloblastic anemia, increased MCV, MCHC, and similar pictures in the bone marrow. It can also lead to fetal loss and neuropsychiatric manifestations ranging from simple paresthesia, pain and numbness to more severe SACD and psychiatric manifestations, as we just discussed some time back. So coming to popularly available laboratory assessment, which has been in clinical practice for quite a long time, what clinicians do is order a simple CBC, which of course many a times is diagnostic of gives enough hint towards the B12 deficiency in the form of megaloblastic macrocytic anemia and elevated MCV, MCHC, or the hypersegmented neutrophil in the peripheral smear. But again, I would like to highlight here that only up to 28% of B12 patients may have a normal hemoglobin level, that is no anemia. And up to 17% can have a normal MCV, that means no macrocytes. So measurement of B12 level, again, it has its own pitfalls, like false low level can be in patients having on oral contraceptive pills during pregnancy, in case of folate deficiency, patients suffering from multiple myeloma, and false normal level can be seen in liver disease, myeloproliferative disorders, renal disease, and in fact, few articles are also writing that in cancers, we can see even false high level of vitamin B12. Another test which is used to assess the B12 malabsorption is the ceiling test, in which oral 57 cobalt labeled B12 is given after a intramuscular injection of non-labeled B12. However, this test is no more in practice nowadays, because better test in the form of intrinsic factor antibody can diagnose the malabsorption of B12 or the pernicious anemia with as high as 95% specificity. We can also measure serum gastrin or low pepsinogen to say that gastric function is defective. However, these tests have their own disadvantage, and the recent trend is to go for multi-biomarker approach. And this slide shows the cutoffs for B12 biomarkers, like serum B12 level. If we look at the level of serum B12 level for adult, this is a WHO guideline which says that a plasma level more than 221 picomole per liter is considered adequate. Between 150 to 221 is considered depleted, whereas less than 150 is considered deficient, with a severe deficiency defined as less than 75 picomole per liter. If we talk about serum holotranscobalamin, the value is between 40 to 150, or few articles are saying 40 to 200, with deficiency defined as below 35 or 40. As far as serum methylmalonic acid is considered, a level more than 271, or few articles are saying more than 375, are considered to be diagnosing vitamin B12 deficiency. As far as total plasma homocysteine is concerned, the normal range is between 5 to 15 micromole per liter. Desirable is less than 10 micromole per liter, and hyperhomocysteinemia is classified as mild, intermediate, and severe, with values between 15 to 25, 25 to 15, or 50 to 500 micromole per liter. So what we can make out from this table says that serum B12 and serum holotranscobalamin both will decrease. MMA and homocysteine will increase in vitamin B12 deficiency. So individually, if we look into this biomarker, we can see what are the strength and weakness of each one. So serum level is reflective of long-term B12 status and liver stores. Assay is widely available, inexpensive, but disadvantage is it takes much time to increase after low oral dose, and these are not very specific or sensitive, owing to a lot of false positive and false negative interferences. However, measurement is very easy. Most of the labs nowadays are having CLIA, chemiluminescence assay, and we can very easily measure the serum B12 level. The only thing is the sample ideally should be protected from light, but again, there is two school of thoughts on the same. The second biomolecule that is total homocysteine, is one of the beautiful marker, because it is actually reflecting the functional or the metabolic adequacy of B12. That is, it is reflecting the status of methionine synthase. Total homocysteine responds rapidly, particularly when the deficient patients are treated with the B12 level. However, as we discussed in the metabolic pathway, it is not specific to B12 alone. It can be elevated in deficiency of folate, riboflavin, or B6, and it also increases in case of renal insufficiency and hypothyroidism. But the beauty is total homocysteine can again be very easily measured by CLIA guideline. The molecule is highly stable under refrigeration and freezing. And since when we are talking only about total homocysteine in serum or plasma, which is not reflecting the true state of the intracellular role of the B12. We must talk about something which we can measure in the tissue homocysteine level or intracellular homocysteine level. And there is a kit there is a ELISA kit in which tissue homogeneate can be prepared to measure the intracellular homocysteine level. So out of B12 and total homocysteine, obviously total homocysteine is much better than the vitamin B12 level. And if at all we are not measuring the intracellular homocysteine, at least we should be measuring the homocysteine in the plasma and not in the serum, because inside the serum, again, there is a of the homocysteine, because homocysteine is released from its bound form to the cellular component. The third biomolecule, that is serum MMA or methyl malonic acid, is the most sensitive biomarker of B12 status. Again, like the total homocysteine, it reflects the adequacy of B12 for the metabolic function. In this case, the enzyme is methyl malonyl CoA mutase. It responds quite early to IV injections of the serum B12. Like homocysteine, it doesn't get affected by other vitamin like folate or riboflavin or vitamin B6. But the major drawback of methyl malonic acid is that we can measure methyl malonic acid only by LCMS. This molecule cannot be measured by ELISA because of lot of other molecules which behave similar to MMA in ELISA. So the only way MMA can be measured is by LCMS, and most of the institutes, even the tertiary care institute, they lack LCMS facility. Again, it increases with the renal dysfunction, and bacterial overgrowth can also cause false high level of serum MMA. The fourth one is the serum holotranscobalamin, and serum holotranscobalamin is better than vitamin B12 because it is providing the information on the B12 which is functionally available to the cells. So and this serum holotranscobalamin, that's why it's the first one most sensitive to the recent intake. It can be very easily measured by ELISA, but the main disadvantage is that we don't have any consensus on the cutoffs that should be used to diagnose B12 deficiency. It is still in the research stage. Only 10 years of studies has published on serum holotranscobalamin, and that's why it is more expensive, and without any proper cutoff, obviously we cannot use it for patient care. Then on these molecules, as a biochemist, we should also be talking about what are the pre-analytic interferences which can actually affect the patient SAM result. So the main thing which I just highlighted, serum B12 sample for serum B12 need to be protected from light. Sample for total homocysteine should ideally be plasma, and it should be separated from the whole blood within 30 to 60 minutes. And otherwise, serum B12 and holotranscobalamin and homocysteine all are stable under refrigeration and freezing. And another thing is affection by the drug treatment. Serum B12 is very easily affected by the common drugs which the patient might be taking, like metformin, which is the drug in type 2 diabetes, then proton pump inhibitor or histamine 2 blocker or antacids, whereas total homocysteine would be affected in case of patients having folate antagonist or Parkinson's patients on L-DOPA, which is less common. So obviously, if we compare the four, MMA is obviously not available to most of the institutes. Serum holotranscobalamin is still in the research stage. We don't have any cutoff. So we are left with serum B12 and total homocysteine. And obviously total homocysteine should be measured to diagnose the serum B12, because serum B12, again, the levels doesn't correlate with the clinical feature. So if we compare the performance, cobalamin and holo-TC both will decrease in B12 deficiency. MMA and total homocysteine will increase in the B12 deficiency. However, this holo-TC, we don't have any cutoffs. MMA, we need lot of infrastructure investment, and in between cobalamin and homocysteine, cobalamin specificity is questionable, and homocysteine, though not specific because it is affected by the folic acid or B6 or riboflavin or mutations in the MTHFR or SNPs in the MTHFR. But still, if other causes are eliminated, we can use a combined approach of cobalamin and homocysteine. So because of these so many advantages and disadvantages with each of the molecule, there was a paper by Fedosov et al. Into 2015, which proposed that a combined indicator of vitamin B12 should be used to diagnose a vitamin B12 deficiency. This was told as CB12. And the mathematical formula included all the 4 parameters along with the age factor. And they gave 5 different levels for CB12, ranging from -2.5 to more than 1.5. And each one had their own significance of probable B12 deficiency or possible vitamin B12 deficiency, up to elevated vitamin B12 in case of a figure more than 1.5. And so this is the picture that they had. This is the table that they have summarized. What should be the biological interpretation when CB12 is more than 1.5 or less than -2.5. But as far as treatment is concerned, supplementation was required in case of B12 less than 2.5, with proper monitoring of the B12 status over time. Whereas for the CB12 level between -0.5 to -2.5, only fortification of the food was recommended. So there are many algorithms because of 4 different biomarkers, each having their own advantage and disadvantage. Various algorithm has been proposed. This one shows the algorithm which we can be used when we have facility to measure everything like homocysteine, methylmalonic acid along with B12. Or for clinical practice, we can use a separate algorithm which says that all patients should be who are malnourished or at risk of developing B12, all institutional patients, they should be measured with serum cobalamin along with total homocysteine. If the cobalamin level is 150, less than 150, then dietary deficiency history is taken. And if dietary history say suggestive of vitamin B12 deficiency, it should be treated. If dietary deficiency is not present, history doesn't say that patient is taking B12 deficient diet, then malabsorption should be suspected. Whereas for value above 150, no further investigation is needed. For this, if malabsorption is suspected, we should check for the possible causes of malabsorption, like any history of the Crohn's disease, lymphoma, tuberculosis, celiac disease, or gastric rejections, or drugs. Then we should think of treating with the cyanocobalamin. Or if pernicious anemia is suspected, then measurement of the anti-intrinsic factor antibody or performing the sealing test. So ultimately, we can come at the cause of the B12 deficiency, and accordingly, the treatment should be planned. Treatment, we all know that it can be ideally hydroxycobalamin IM injections, or it can be very high doses of oral. I'm not going to discuss on the treatment part. So what are the guidelines as far as the vitamin B12 diagnosis is concerned? So till today, as far as whatever articles I have searched, I couldn't find any recommendation from American Society of Hematology for diagnosis or treatment of vitamin B12 deficiency. American Academy of Neurology recommends measuring B12, MMA, and homocysteine in patients with polyneuropathy. And again, I would like to highlight that there is no consensus on cutoff value of holo-TC for B12 deficiency, and of course also for total homocysteine to be used as a marker of B12 deficiency. So this brings us to a lot of gaps and needs which should be like taken care of. Like we need validation of biomarker cutoffs, and we need to know the cutoffs for age-defined and gender-defined reference range before we start using these biomarkers in a larger scale for actual patient benefit. We also need to test the validation of combined B12 as an indicator of functional B12 deficiency. Again, we need to have methods, analytical methods, which can be used in large population at community level for diagnosis of the same. We also need to know whether holotranscobalamin can be used as a best biomarker in pregnancy, because obviously whenever a pregnant lady is having a deficient B12 status, it is going to affect the neurological development of the developing fetus. Assessment of functional significance of low B12, particularly in at-risk persons like in pregnancy, lactation, infancy, and young children should also be taken care of. And then last one, we need to know whether repeated consumption of high dose of B12 is safe or no. In one of the article I read that people presenting with neurological manifestations, the cases, they were advised to undergo IM injections of up to 1000 microgram of the B12 twice a week. But after 4 weeks, the serum B12 level was above 1400. So fearing a toxic accumulation of B12, the drugs were stopped, and the patient then had more pronounced symptoms of paresthesia and neuropathy than it was before. So that paper highlights that when on IM injections, ideally B12 level should not be measured routinely in the blood. Rather, other biomarker for assessing the level of B12 should be used, whether about total homocysteine and MMA should be employed. And even if at all the need of toxic concern is there, then the gap between the two injections should be lengthened, but the doses should not be stopped at all. So back to our primary case, that is the person presented with painful paresthesia in leg for 18 months and vitamin B12 level of more than 365. What we should do? So the patient was was measured for serum methyl malonic acid, and it was more than 3600 nanomole per liter, which is way above the normal cutoff of 400 nanomole per liter. The serum homocysteine level was found to be more than 49 micromole per liter. The cutoff was less than 14 or 15 in this case. So conclusion for this case is the patient's neurologic abnormalities are consistent with B12 deficiency, though documented B12 deficiency by serum B12 level is not there. However, MMA and total homocysteine both should always be measured whenever the clinical presentation doesn't coincide with the laboratory measurement of B12. Further testing of the cause of B12 deficiency, whether in the case of pernicious anemia, should be measured by measuring the anti-IF antibody. And then patients should be treated by parenteral B12 level. And once B12 injections are initiated, the blood counts improves in 2 months. Neurological manifestations takes up to 6 months to improve. So again, if we talk about the guideline for screening of the patients for B12 deficiency, so we don't have any US Preventive Service task force guideline, no published guideline for screening of asymptomatic patients. There is no other medical organization who recommends screening of low risk patients. So only way we can establish one case as a B12 deficient is to consider screening patients having any risk factor. Any presentation which cannot be accounted to any other disease should be screened for B12 deficiency. Initially, it was thought that only the people who are having a vegetarian diet, they are more predisposed to B12 deficiency, though that is true. But presuming that those who are having non-vegetarian diet cannot have vitamin B12 deficiency is totally false. So a take-home message from today's lecture would be vitamin B12 deficiency is underreported. The actual incidences can range from 5% to up to 60%. Keen interest of the clinician to measure the B12 level, not alone by the serum B12 level, but by other biomarker like total homocysteine, or wherever there is suitability and the infrastructure is available, supplementing with serum methylmalonic acid or with holotranscobalamin should be used. MMA, though best, but again, it is the question whether the facility is there or not. And wherever possible, a combined approach, that is combined B12, should be used, or researchers should try to devise a new algorithm model incorporating those parameters which can be easily measured, like incorporating B12 level, incorporating total homocysteine in the serum or the plasma, or even for the cellular homocysteine, intracellular homocysteine, or any of the parameter of the CVC like MCV or MCHC, or presence of number of hypersegmented neutrophil. So those algorithmic mathematical model, if is proposed, then maybe we in near future we will see more of B12 deficiency and documented incidences of B12 deficiency would increase. These are my various references. I think I'm on time. With this, B12 deficiency can ideally be cured by IM injections, and deficiency is actually a trap. Thank you.
You have covered everything. There is a question from Roshni who is saying, how can we measure intracellular?
For measuring anything intracellularly, the ideal is to go for mass spectrometry. Like we need to measure inside the cell. So we need to prepare the homogenate, cellular homogenate, and then we need to measure it by mass spectrometry. So most of the time it is not available. That's why we, all the biochemists, we thrive on the either the plasma or the serum.
Yes.
Thankfully, we have 1 or 2 ELISA kit for homocysteine, which in fact I'm thankful to Dr. Vidya. She only shared with me one of the literature saying that yes, there are ELISA kit which are saying that we can
Yes.
intracellular homocysteine level, but mostly like those measurement would not be without any errors. So that's why we measure everything in serum or plasma.
Yes. We have a question by Sachin Patarkar. Please, over to Sachin, or you can just type.
Someone has written that all my references were US Sadly, we don't have published literature from India. That's why I have highlighted that research gaps and needs.
Yes.
We can very well try to devise our own mathematical model, taking into account CBC, as we already have Dr. Aparna, who is a pathologist. So we
Yeah.
can use both the expertise of a pathologist and of biochemist, and of course of the clinician, and we can propose some mathematical model taking into account B12, total homocysteine, and any of the parameter of the CBC, and we can propose a mathematical model, and then we can proudly say that our references is Indian, or we can be a references to US people.
Yeah, in consensus with Dr. Seema, I feel yes, all diagnostic area of test will have their own advantages and disadvantages. And as we are again coming to the common goal of integrated diagnostics, yes, definitely with HAMAT and pathology people, we can develop our own algorithms so that we detect early insufficiency also. See, insufficiency also should be detected at an early age. And one question was there for we done by clear for some patients we get vitamin B12 more than 2000. What's the reason for more than 2000? Seema, can you answer this? B12 more than 2000. Yeah.
In our clinical lab also, we come many a times we come across with cases having more than B12, and we used to think before this presentation, even I used to think that like patient has been overtreated, but now I feel maybe the patient is on IM injection and the B12 level will reflect the ongoing treatment. So one should not get worried about it. Rather, whether the clinical features are getting improved, and that should be ideally looked after. We should not get worried about more of the B12 level, but again, high B12 level is being reported in many myeloproliferative disorders and in cancer. So that should be checked. Otherwise, as far as documented B12 deficiency and ongoing treatment, B12 level should not worry the clinician much.
Yes. That's, I think
There
we
was
answered
one
your.
more, there was one more comment, like there is no mention of the unit in combined B12. Of course, combined B12, they have got the
Yeah.
factors, and log of product of two parameter over product of another parameter is taken. So I believe they must have negated all the units in the same unit way.
Yes. Yes. So, is it?
There is
So
one
that
more question. What condition
yes.
we want to check homocysteine with B12? So
Mm.
ideally, homocysteine nowadays, in fact, 2 days back, only one of my microbiologist friend rang me up saying my husband is having high homocysteine, though B12 is normal. So should I be worried? I thought I told them otherwise I should have I would have been very worried myself. But after going through so much literature, I just told that you assess the folic acid first without getting worried about the cardiac risk. So and that is the thing. Like if for assessment of cardiac risk profile, for assessment of folic acid deficiency, for assessment of any anemia, for an assessment of any neurological manifestations, or any clinical picture which is not documented by any other causes, then we should think of measuring the B12 along with
Yes.
homocysteine.
One more question from Dr. Shilpa. She says, why will not intracellular homocysteine levels be affected by folate deficiency?
Sorry, I couldn't hear it properly.
Yes. Will not intracellular homocysteine levels be affected by folate deficiency?
Intracellular homocysteine will definitely be affected by folate
Yes.
deficiency, because for conversion of homocysteine back to methionine, we need methylcobalamin, and the only way we can get methylcobalamin is from the like methyl tetrahydrofolate. So that's why we're saying homocysteine is having its own pitfalls, its own disadvantage. It is not specific for B12 alone.
Yes. Two more questions. One is, for what condition we want to check homocysteine with B12?
That I just answered. Like
Correct. How much period requires to improve symptoms after vitamin B12 supplement?
One of the
Yeah.
paper discussed that hematologic parameters will improve within 2 months, and neurological parameters will improve up to after almost 6 months. That's why, like one of the article, it discussed about a lady who was having neurological manifestations, and after 2 months of IM injections, when the clinicians measured the B12 level and found it to be more than 2000, the patient herself, she stopped taking injections, saying I will end up in having toxic accumulation of B12. And after 6 months, she presented with more aggravated neurological damages. So ideally, like for reversal of neurological manifestations, if at all it is reversible, will take more than 6 months. So we should not be worried. Within 2 months, we should not be go on checking the B12 level and thinking that whether we are ending up in toxicology, like toxic doses or not.
Yes. Sachin wanted to ask, there were no units. Yes, there were units. Sachin, there were units for MMA and B12. It was already given in the table form. She had put a very nice reference, Fedsaw et al., which are suggesting it was a nice comprehensive table which was giving suggested cutoff and interpretation. In that, it was there. Sachin. Yes. So,
Like just I told some time back, no, they while calculating CB12, they must have like kept all the units of MMA, B12, holo TC,
correct.
and T homocysteine in the same way. Like
Yes.
for that, like we need to first, like supposing it is over two parameters on the numerator and two parameters on the denominator, we are taking log of it. If we kept the unit of the numerator same as that of denominator, we will end up having no units. I think that's what I can, if you have some other suggestion, you can please suggest, but this is how that comes to my mind.
Yes. Yes. And one more question by Gohan. He is asking, I think it's in the chat. Highlight the specific advantage of intracellular homocysteine over plasma homocysteine.
See, ultimately, whether we talk about any vitamin, any enzyme, the main function of these vitamins, minerals, and enzymes are inside the cell. So the function is inside the cell, and we are measuring something outside, which is just a reflection of what can be inside. But from inside the cell and to the outside, there are a lot of other interferences which can play into. So that's why anything which if you are able to measure inside the cell, will definitely be much better than something which is measured extracellular or in the serum or the plasma. As far as if you compare serum and plasma, then definitely plasma is better, because in plasma, the homocysteine which are bound to the cell are not released. So you can compare it better. Whereas in serum, you will get a false higher level of homocysteine.
Yes, that was excellent. Yes. So it will be very nice. Yes, Sachin, we will give you the access so that you can talk to Dr. Seema directly. And so if there are no more question and answers, I would like to conclude that whatever Seema said in her 1 hour presentation, she has concluded that we should have a group of assays or arrays. It is serum B12, total homocysteine, methyl malonate acid, holotranscobalamin. All of them have their advantages and disadvantages. She also mentioned plasma homocysteine is better. See, this is the pitfall where laboratory follows. We usually do the serum homocysteine. So with
Yes.
such platforms, we come to know, right, plasma is better, and it's very easy to get a plasma, right? When
Yes.
from a patient, yeah. And also when you talk on, yes, all tests, I mean to say we need to have a proper algorithm. And as she already mentioned, there is a huge research gap. I have a very nice, I mean, I want the youngsters to take up this, where there is a research gap. Yes, there is a research gap in validation of the biomarker cutoffs, and we should develop multiple biomarkers and put them into practice. And there should be some screening protocols for national policies so that insufficiencies also can be detected earlier. So with that, I would like to conclude the session. Once again, Dr. Seema, in spite of your vacation, your contribution is highly commendable. And thank you so much for for agreeing and being the speaker for today's topic. Thank you very much once again.
Thank you so much, ma'am. Thank you so